It's still no clearer exactly how 3 nurses caught COVID-19 while treating patients with the virus at Waitākere Hospital, but an urgent reviews identified serious issues with the PPE provided. It found the PPE didn't always fit and that staff were forced to change it up to 8 times a shift, just so they could communicate with doctors who weren't allowed on the ward. The nurses themselves are commended for providing exceptional care to the 6 residents from the St Margarets Rest Home, but the report paints a grim picture of the realities on the ward, finding that the hospital wasn't prepared to deal with high care needs patients with COVID. The review focuses on how the first 3 nurses caught COVID-19 at Waitākere Hospital. Since it was finalised, a further 4 nurses have tested positive for the coronavirus there. Speaking a short time ago, the DHB's Deputy CEO, Dr. Andrew Brant, took the opportunity to apologise.
We're deeply sorry about what has occurred to these 7 nurses, and we have apologised to each of the nurses that they should contract COVID-19. And it is incredibly regrettable.
Let's get to some of the specifics here. I want to read you an extract from this report. It says, Monday, 20th of April, a particularly busy and challenging day for staff, with 1 patient deteriorating rapidly over the day, with oxygen needs progressively increasing. One of the patients died and had to be placed in a waterproof body bag, which was a different bag than the standard body bag. This was a particularly stressful time for the staff, as some patients were unwell, confused, incontinent, and requiring full care. This was the only time that the 3 nurses who tested positive for COVID all worked on the ward on the same day. Given the high needs of these patients, should you have had more staff on that ward?
Well, as the report highlights, throughout the interviews of the panel, there has been no concern about the number of staff or the staff mix on the ward during that period of time. And yes, I think that absolutely describes the situation of the clinical conditions that the nurses were facing, and they did an exceptional job of caring for those patients during that period of time.
They did an exceptional job, according to the report, but could you have done better? For example, if you had had more staff on that ward, it would have meant that staff who were working there didn't have to take their PPE on and off so many times to go out of the ward and get assistance. So, should you have had more staff on?
Well, as I say, the report doesn't actually highlight that issue. In fact, there was consistency of everyone interviewed. They thought that there was enough staff and a good case mixture of staff at the time. One thing, though, if you do see in the report that is a lesson to be learnt out of that, is actually making sure we fully implement a buddy system. What that means is that every time that someone actually puts on their PPE, is that they are observed and checked and before going in and out and caring for patients. And so that is something that we have implemented straight after that as well as obviously auditing, which is actually an improvement piece where someone's there always looking, saying, look, just check your gown, check your glasses, check the mask, and make sure that's done every time.
So some of those workers were having to change their PPE up to 8 times a shift. And you know that is one of the most risky times with a communicable disease, getting in and out of that gear. So how much greater was the risk of infection that they were exposed to because of poor systems?
So if you look at the report, it's just really highlighting that is actually what was required to look after the patients at that time.
Because there were no doctors on the ward and no basic intercom system so that they could communicate with people without getting changed in and out of the gear.
There's absolutely medical staff were available. What this report is highlighting is that actually what we need to do is reduce the frequency of needing donning and doffing PPE when we're looking after patients. I think that's a very important point, and there's some very helpful things in this report to help reduce that. For example, yes, making sure there are two-way communications inside the room and outside the room, so one doesn't have to go in and out of the room, for example. I think a further initiative is making sure we've got good communication devices inside with the patient, with their family, would be another very good example. And so I think they are lessons to be learned, and that's why this is a very, very important report. And I very much encourage everyone to read the report in the health sector around the DHBs with found the aged residential care because there are some important lessons to be learned to help prevent this in the future.
Dr. Brant, in terms of the access to doctors, they could have access to a doctor if they left the room, meaning they had to get in and out of their gear, correct?
That is correct, and it's not unusual for if a nurse is nursing a patient and then they need to see the doctor, they go out of the room, and therefore maybe the doctor may be there or they may have to call. So that's just one of the areas that's been identified in the report, is what are the things that we can do to help reduce the frequency in and out. There's one other thing that I think is very important to stress in this report. This report is highlighting issues such as that, but it hasn't actually identified particularly the cause. What that report does is actually highlight a high-risk time where all three nurses were working on a similar shift in a quite difficult clinical situation. And so it's sort of highlighting that probably was the risk time. So therefore, it's really important. We have done this work, we've analysed it, we've pulled out the lessons from this to make sure that this doesn't happen again in similar.
Okay, understand that. Let's look at the PPE. You have said the DHB has said it was supplied at all times, but there is an issue around the standard of PPE that you supplied, isn't there? Was it adequate?
Oh, the quality of the PPE is not in question, or the supply of PPE. What this report is highlighting is that actually there's been changes of the PPE in the
I'm sorry to interrupt. I'm sorry to interrupt, but this is an important point. There is an issue with the quality at various points. They talk about the eyewear not being suitable. They also talk about faulty tags on the gowns. They talk about the staff using masks that had not been fitted. They talk about inconsistency of the equipment, with nurses having to learn to put on different types of gear because they weren't always getting the same supplies. That is deficiencies in the PPE, isn't it?
So what that is describing is that making sure that the PPE is supplied is appropriately put on, and that is why it's very important that we've actually instituted the buddy system. So you put on your new gown, your gloves, your eyewear, your gown, and someone there is observing you to make sure that actually, yes, that's all exactly right. If you, in that circumstance, for example, is saying, look, actually, check your tag, make sure that glass is looking a bit loose, someone's there to actually check that before actually going in and see the patient. That's a very important initiative. So I think what that's highlighting is that, look, when we actually put on PPE, and if you're doing it a number of times, you've got to check. And that's really a really important message that's coming out of this report.
Understand the checking, but I'm going to refer you to point 22 of the report that says the Velcro tabs on the gowns were loosened and easily created gaps in the back. They refer to the initial eyewear, which had removable lenses that would flick when removed. Initially, the eye lenses needed to be cleaned, which meant that alternative eyewear had to be provided for some days. Different brands of N95 masks were supplied, and initially staff had not been fitted with those new masks. So there were faults with PPE and the way it was supplied to staff.
Yes, how I've described that is that when you actually put on PPE or equipment, you've got to be checked that it's actually put on properly and checked. And that's why the checking is such an important piece. So I'll just give an illustrative example around, say, the gown and Velcro. Well, those gowns
I do understand that, Doctor, yes, but I suppose the point is you can check the way the equipment is put on, and that is a backstop. But if the initial supply of equipment is not up to scratch, that's also an issue too, isn't it? And that was one of the problems you had here.
What you've outlined, that's not what actually that's describing. So let me just say, if I can illustrate the point, you've raised the issue regarding the Velcro. Well, they're on gowns that have been used for many years around within our DHB and other DHBs. That's actually just highlighting the issue that actually make sure we actually apply the Velcro properly and then actually have someone actually observing it. That wasn't really a comment about actually the quality of that gown, for example.
The glasses, the goggles then?
The similar issue. So that actually evolved and actually was one of the things about different supplies over time. So what that is about is that we have goggles and they have lenses on them, and actually they were designed to be cleaned, and that's good. But we did find that actually, when you actually take off the lens, it may flick. So what did we do regarding that? Well, we've actually said stop doing that, even though they're reusable, just use them as a one-off. Actually, we now moved on, because there's different suppliers, we've now moved on to goggles. And we need to make sure that whenever the new supply comes in, that they are appropriately fitted.
How do you think these nurses got it then?
Well, actually, it's the role of the public health physician in Auckland Regional Public Health to help determine that, and you probably see in the report, where their conclusions are at the time. I think what we're doing is they're pointing towards that day that you highlighted, where the patients had clinically deteriorated, and as a result of that, there was a lot of in and out of the rooms.
And that is the DHB's Deputy CEO, Dr. Andrew Brant.